Okay, thank you. So we are going to go very, very quickly this afternoon just to be sure that we are going to finish in time. So please respect your time. And now, you know, I'm going to make a special talk just after or before the break about how our partners who permits to organize this wonderful symposium in this place. But Allergan proposed to us a specific presentation introducing the PSS Risk Classification System as a new tool for the early identification of PSS. And they asked to Philippe Marque to make a short talk about that. Thank you, Philippe.
Thank you, François, to invite me. It's a real pleasure to be there. I see that we're getting older and older because we have some meeting yesterday evening, and now this morning I have a good voice. I have not the voice of Joe Cooker, and it's a private joke for you. So, what is PSS system? It's a board of experts driven by Jörg Wissel, where there is few of experts of spasticity. Few of them are in rooms. And Allergan give us the facility for driving it in around the Congress of Copenhagen about toxin. What is the challenge? The challenge is for stroke patients. That stroke is a really frequent pathology. It's the first disabling pathology over 40 years old. In French, it's 140,000 patients per year. I don't clearly imagine what it means, but in my area, I'm clear. In my area, the prevalence of multiple sclerosis is 3,000 patients. Head injury is around 1,000 patients. Spine injury is 1,000 patients. But the incidence of stroke in my area, in my district, is 5,000 patients every year. So it's impossible to see every patient clearly. And now with stroke unit, we don't see really early a patient. We see them after. So how us, specialists of spasticity, we can have the good patient at the good place? That's the question. The post-stroke sequelae, you know that clearly. That's post-stroke spasticity and motor impairment. And motor spasticity is really, post-stroke spasticity is really interesting because there is a treatment. Clearly, there is a treatment. So the idea is not clearly proof in the literature nowadays. The idea is that early identification of patients at high risk for spasticity to develop could result in earlier treatment and possibly to a better outcome. The idea driven by Jörg Wissel comes from his systematic review of literature published in Physical Rehabilitation Medicine in 2015. And you see the incidence in the 9 study chosen by the systematic review. The incidence of spasticity, clearly, it's a clinical something evidence, clinical evidence, raised with the time. It's between 4 and 15% during the first weeks. It goes to 14% at the end. We don't need to treat all the patients, but we need to be able to see this patient if they need to be treated. So how we can challenge it? No, it's in this systematic review, there is some data about the fact that early after stroke, there is some clinical symptoms which are associated with late post-stroke spasticity. The first one is severe motor impairment, clearly. Sensitive trouble are also really associated with it, and there is some other trouble. So the idea is to build a tools really easy to read, really easy to understand, dedicate not for you, but for primary outcome nurse of stroke patient. And we have decided to have something like a traffic light for helping general wards and physiotherapists to orient the patient. So clearly, it's not for you. It's for primary care doctor, non-injecting physiatrists, and physiotherapists. And the idea is to try to organize, to have an algorithm for orienting the patient to a specialist of spasticity. So it looks like it. You all have in your bag this model. So it's one size paper. So there is high risk of spasticity. You have moderately, markedly, or severely increased muscle stiffness across 2 or more joints. You must have to see some specialist of spasticity. Severe loss of sensory motor function, severe decrease in surface sensation and period proprioception, and severe motor dysfunction. That's early after stroke. That's a symptom early after stroke. You may refer your patient to specialists and to a team of specialists of spasticity, and it's clearly the time to initiate physiotherapy. Perhaps not the case in France because all these patients have physiotherapy, but in some country it should be the problem. If you have mildly increased in muscle tone across one joint and voluntary mode, you could have a consultation with multidisciplinary team. It's routine referral, there is no emergency, and you could send us for initiate physiotherapy before to have a multidisciplinary care advice. And there is some patient that you could just monitor periodically. If patient have persistent dexterity, problem in absence, in increase in tone, that you could do that. So that's a really simple tool. There is still some question about include other factors like smoking. For smoking patients, there is an increased risk to develop post-stroke spasticity. That's the same thing. There is a difference between left-sided stroke and right-sided stroke. And for those who want to enhance manual activity prior to the stroke. So that's this really tool. I engage you to have a look on it, and I thank you for it.
Have you used the tool yet, Philippe?
Not yet in my, but it meets some of my minding and some aspect. I'm involved in my area to teach to the physiotherapists the possibility to refer us the patient with a specific point of view. We go a little bit further with the idea that the physiotherapists, liberal physiotherapists, not physiotherapists of my department, of my district, have the possibility to assess the efficacy of botulinum toxin injection, for example. So there is probably, I think, some adaptation from one country to the other because the system is not clearly the same in each country. But I think I clearly share this advice that we should have some simple communication tools for share the possibility to refer the patient.
And just the point where you said it's not for you, it is for us because you're suddenly going to be getting referrals. Can you see this person urgently? And you're going to say, I'm busy and I have a waiting list. I work in acute care hospital, so we inject people 4 or 5 days, sometimes after, when they develop very severe tone that the physios really are struggling with. So you may have to change your practice to say, yes, you've called me as a physiotherapist or a neurologist, this patient needs urgent care. It's a very quick consult, it's easy to do, and you will change the course of their spasticity forever, versus someone who's 1 year, 6 months, 2 years after their spasticity. So they might never need orthopedic surgery. Many of them just need 1 round of toxin and they get better. So we are asking you, when these referrals come in, please prioritize them because you'll get very good results.
Yes, so you're right, Paul. It changed. It's the paper is not for us, but the consequence of the paper are for us.
Thank you. So, okay, Ted. Last very short question, and after we finish the morning,
So I will get rid of the question and just make a statement. Just all of this data you presented by Jorg is really predictors of spasticity within the first 2 weeks, and,
Yeah.
and making this generalized assumption that we should do this long-term in the community. I just want to point out these outcome measures are based on changes found within the first 2 weeks, which really apply to anybody in a stroke center or within their first week in rehabilitation.
Yes, you're right.